So I have a confession to make. Despite priding myself on doing minimally invasive spine surgery or non-surgical management of back pain and things like cervical disc replacements or microdiscectomies, decompressions, things like spinal cord stimulation for chronic low back pain, multifidus stimulation for multifidus atrophy. Despite the fact that I do all that, some of my happiest patients are lumbar spine fusion patients. And part of the reason I wanted to make this video is because even though I'm an advocate for doing less fusion and doing more motion sparing or non-invasive interventions, I feel like sometimes fusion has become the new F word in spine surgery. And granted, everyone who I talk to, most of my patients, know someone who had a back surgery that went badly, or they didn't have a good outcome, or they had screws and rods, or they had to keep going back and having more surgery. So I want to talk about when it's appropriate and when it's not. So prior to spine fusion being widely available, a lot of pathologies in spine surgery were difficult to treat. Among them were spine fractures from trauma, slippages, something called spondylolisthesis, unstable spines, or people with deformities of their spine like bad scoliosis, or what we call like a flat back syndrome or positive sagittal balance, where people are bent forward when they're walking. Before modern instrumentation, those things were really hard to treat and they were often disabling. Now, since then, we've had access to the technology and it's really revolutionized the way we treat a lot of these disorders. But like many other things, it can sometimes be overused. And, some of those are educational, some of those are, unfortunately, there's financial incentives involved with spine fusion. So what I want to talk about, without getting too far into that, is when is spine fusion appropriate, and what are the things that could lead to failures? So first of all, spine fusion is valuable when there's true instability of the spine, like in the setting of a fracture or a mobile spondylolisthesis or malalignment of the vertebrae. It's also really valuable when someone has a collapse of the space in between their vertebrae, like from a really degenerated disc, that causes narrowing of the foramen, which is where the nerves exit the spine. Sometimes in cases like that, where the foramen is really narrowed, sometimes the only way to fix it is by increasing the distance between the two bones. And really right now, interbody fusion is the best way to do that. There's a little bit of misunderstanding of when we use the word stenosis. Stenosis, or narrowing of the spine, can happen in two places. One, it can happen in the central part of the spine, which is called central stenosis. And that oftentimes we don't need to do fusions. But then the other type of narrowing is something called foraminal stenosis, where this is where the nerves are exiting in between the bones of the spine. And sometimes fusion is really helpful to increase that height distance. Sometimes you can do things called foraminotomies, which basically is like shaving the bone to make more space for the nerves. But oftentimes, if the height loss of the space between the bones is too much, sometimes a foraminotomy won't work. But then the other thing I think we don't talk enough about with fusion is that sometimes when people need a big decompression of their spine, if someone has compression of the nerves in what's called the lateral recess, which is the far lateral edges of the spine, sometimes in order to open up that area, you have to resect a big portion of the joint. You end up having to do a fusion because you're creating instability. And so in my mind, doing a fusion enables us to do a better nerve decompression. And something I've lectured on to other doctors and other spine surgeons is, I think where fusions go wrong is when we're simply relying on the screws or the rods or the stability to make the patient better, rather than using the screws as an aid to allow us to do a better decompression. Most patients with degenerative spine conditions are symptomatic from nerve compression. And so when we do everything we can, and if we use fusion as a tool to decompress the nerves, then patients feel better. On the other hand, in a patient with just classic back pain, and I'm not talking about patients with bad spinal deformities, if they go in and they, get a mediocre decompression of their nerves and then just get some screws and rods to sort of, stabilize the area, those patients don't tend to do better. Interesting story. I was seeing a patient once, and they got a second opinion with orthopedic spine surgeon, someone who I actually know and respect in the community and who I think does a good job with surgery. But I was kind of surprised that patient came back to me and decided to have surgery with me. But what's funny is what they told me that the other spine surgeon said. And the other spine surgeon said, well, your problems with your spine, so you don't need to see a neurosurgeon. And the patient said, why? Well, and he said, well, it's because this is a bone problem. It's not a nerve problem, right? And I just thought that was funny because the truth is, what makes the spine special in all aspects of orthopedic and neurosurgery is that it really is both. So yes, it's a bone issue, but the bones house the nerve, so it is also a nerve issue. And so anything we do, whether it's fusion, whether it's decompression, whether it's a disc replacement, all of those things have to be done in the lens of how can we decompress the nerves to make patients better. And if fusion is the best way to do it, I think it's a great tool. On the other hand, if it's something that we think just the fusion itself is going to do the job, then that's certainly the wrong way to look at it. So that's the first part, which is, when is fusion useful? Now, the second part of it is, well, why do fusions fail? And so, number one, fusions often fail when the indications aren't correct. So, again, if we're doing fusions just because we think it'll help someone's back pain, then most likely you're not going to be very successful with it. The second part is if there's a technical problem, if you don't do an adequate decompression with your fusion, those patients will still have persistent pain despite fusion. Um, Obviously, if the fusion is done incorrectly, like you have a screw that's compressing a nerve or something of that nature, that's an obvious mistake. Hopefully, that doesn't happen much. But that's another reason a patient won't do well with fusion. And then the last one, which I think is the thing we hear the most about, is this thing called adjacent segment disease. So what that means is if someone has a fusion, it can sometimes increase the stress on the bones above and below. And if that happens, patients might need another fusion in the future. Now, certainly part of this is because we take a mobile segment of the spine and we make it immobile, which means that the other parts of the spine have to take up the um, the slack basically, and now they have to do the movement. To me, this has always been the biggest reason to do disc replacement. I'm a big fan of disc replacement, especially in the cervical spine. In the lumbar spine, I'm a little bit more conservative about it because I think the mechanics of the lumbar spine and the pain generators of the lumbar spine are a little bit more complex. And also the data on lumbar disc replacement to me isn't as robust as in the cervical spine. But oftentimes, again, with the cervical spine, patients come in and say, well, the nice thing about cervical disc replacement is I can retain my range of motion, which, yes, that's important. But the truth is, most of the levels where we do disc replacement are not responsible for a big part of the motion in the spine, in the cervical spine. In the cervical spine, almost all of the motion is really from C2, which is at the top, up to the base of the skull. And all that together accounts for about 75% of the range of motion, whereas the rest of the spine is pretty stable in the lower cervical spine. So to me, disc replacement isn't as compelling just to maintain range of motion. It's actually more compelling because we believe that there's a lower incidence of adjacent segment disease, which means that it's less chance that you would need surgery in the future at a level above or below because the disc replacement allows for motion rather than a fusion, which doesn't. But in the lumbar spine, there's one other factor that causes adjacent segment disease that I think people don't talk enough about, and that's this concept of sagittal balance. And what sagittal balance means is how well your head sits over your pelvis. And really, there's a number of functions of the spine, but I think the foremost is really that it's meant to keep the head centered over your pelvis so you don't tilt left or right or fall forward when you're walking. And so the way sagittal balance comes into play with adjacent segment disease is it's been shown that in patients where sagittal balance isn't maintained after a fusion, then patients have a 10 times higher rate of requiring adjacent level fusion surgery in the future. Technical way of looking at this is looking at something called the pelvic incidence and the lumbar lordosis. And those terms are really simple when you break them down. Basically, pelvic incidence refers to how much your pelvis is pointing your lumbar spine towards the floor. And lumbar lordosis is the backwards curvature of your lumbar spine. So if those are within 10 degrees of each other, we generally think that your lumbar spine is balanced. And if it falls out of that, then you're at risk of having adjacent segment problems. And again, these are technical terms, but the way to think about it is really simple. If my pelvis is rotating my lumbar spine down, then basically my lumbar spine has to rotate backwards to maintain the center of gravity. And historically with fusions, a lot of times we get what are called flat back fusions, which means that we would reduce the lumbar lordosis in the lumbar spine. And importantly, most of your lumbar lordosis is actually in the bottom two levels, which is L4-5 and L5-S1. And these together account for almost 2/3 in most patients of the lumbar lordosis. So if you do a fusion at one of those levels, but you fuse someone instead of 20 degrees, let's say, which is an average for L5-S1, but you fuse them at 2 or 3 degrees, you lose that excess 15 to 18 degrees of lordosis, which the rest of the spine has to make up for, which puts more strain on the disc, which leads to accelerated wear and tear, which leads to adjacent segment disease. Some ways to fix this or some ways to address it. So I do a fair amount of lumbar fusions, especially at L5-S1 from an anterior approach. That's one way because we have more access to the disc and we can put in more lordotic curvature. There are people who do only posterior but are very mindful of maintaining the lordosis. All of those are fine as long as you're paying attention to the outcome. To me, those are kind of like the biggest things about fusion and why the concept of fusion always being bad is actually a pretty complex topic. I hope this video is helpful. If you have any questions, I'd love to see them in the comments and I'll try my best to answer them. But thank you for listening.